Few nutrition fears are as persistent as the fear of protein, and almost all of those fears eventually point to the same place: the kidneys. People are warned that higher protein intake stresses the kidneys, that it overworks them, and that it causes long-term damage that won't be noticed until it's too late. That framing makes the risk feel invisible and irreversible, which is exactly why it sticks. Kidney disease is serious, kidney failure is frightening, and because the condition can be silent for a long time, the warning feels like something you should obey even if you don't understand the details. But when you trace where this fear actually came from, a very specific pattern appears, and it is not the pattern most people assume. Protein kidney fear did not originate in studies of healthy adults. It originated in clinical medicine, specifically in people with established kidney disease, where clinicians have to manage symptoms, slow progression, and reduce metabolic burden in an already impaired system. In patients with significantly reduced kidney function, protein restriction is sometimes used as a medical tool. When kidneys lose the ability to clear nitrogen waste efficiently, reducing protein intake can reduce symptoms and, in some cases, slow progression, especially when paired with other disease management strategies. That is real medicine applied to real disease. The key point is context. Those patients already have damaged kidneys. Their kidneys are not functioning normally. Protein restriction in that setting is disease management, not a general rule about what protein does to healthy kidneys. The mistake happened when findings from kidney disease populations were generalized to everyone else, as if the same logic applied to healthy physiology. Over time, the nuance disappeared, and what remained was a simplified cultural rule. High protein is hard on your kidneys. Once that rule is lodged in your head, it is hard to unlearn, because it sounds cautious and responsible, and because almost nobody explains the missing context. Here's the distinction that almost never gets stated clearly. In healthy adults, kidneys are highly adaptable organs. When protein intake increases, kidney filtration rate often increases as well, a response commonly referred to as hyperfiltration. For decades, hyperfiltration was treated as a red flag because the word sounds pathological, like something is being forced or strained. But increased function is not the same thing as injury. Your heart rate rises during exercise. Your breathing rate rises during exertion. Blood flow increases when tissues demand more oxygen. Those changes are not evidence that your heart and lungs are being damaged by movement. They are evidence that the system is responding to demand, which is what capacity looks like. The kidneys respond to demand in the same way. If protein intake rises, filtration can rise to handle a higher nitrogen load. In people with normal kidney function, that adaptation has not been shown to cause progressive kidney injury. This is one of those places where language creates fear. People hear stress and imagine damage, but in physiology, a system responding to increased demand is often a sign of reserve, not pathology. Another reason this fear persists is that people confuse association with cause. Kidney disease becomes more common with age, diabetes, hypertension, and vascular disease. Because protein restriction sometimes appears in disease management advice, the brain makes a simple association: protein must be the cause. But in many cases, protein restriction is a response to existing damage, not evidence that protein created the damage. This is a classic error in how nutrition advice spreads. A strategy used in one clinical context gets repeated without the clinical context, and then it becomes a lifestyle rule. Over time, it gets repeated as common knowledge, even when evidence in healthy populations doesn't support it. Lab values add another layer of confusion. People hear that higher protein intake can raise creatinine or blood urea nitrogen, and those numbers sound alarming because they are associated with kidney function. But creatinine is influenced by muscle mass and muscle turnover, and blood urea nitrogen reflects nitrogen handling and hydration status, not kidney injury alone. A more muscular person can have higher baseline creatinine with perfectly normal kidney function. A person who trains hard can have fluctuations that reflect muscle metabolism, not kidney damage. Dehydration alone can raise BUN without any kidney injury at all. Even a high-protein meal can shift these markers temporarily because the body is processing more nitrogen. So yes, the numbers can move in the direction people fear, even when kidney function is stable. Without interpretation, the fear gets reinforced. This is one reason people feel like the labs proved it, when the labs are often showing physiology, not pathology. If you lift weights, this can matter even more, because trained bodies often look different on paper. A muscular person can look worse on certain labs even with normal kidneys, and a sedentary reference range can be misread as a warning sign. That doesn't mean you should fear protein. It means you should interpret labs in context, ideally with trend data over time, and with a clinician who understands what the numbers mean in active people. Now, here's where most public discussions go off the rails. People want a single universal rule. They want someone to say, protein over X grams is dangerous, or protein over X grams per kilogram will harm your kidneys. And because kidney fear is emotional, people prefer certainty, even if the certainty is wrong. But biology doesn't work that way. The honest question is not, is higher protein dangerous? The honest question is, dangerous for whom and under what conditions? For someone with normal kidney function, the evidence does not support the claim that moderately higher protein intake causes kidney damage. For someone with established kidney disease, protein targets may need to be individualized depending on stage of disease, symptoms, medications, and clinical goals. Both statements can be true at the same time. Confusing them is what creates fear. This is also why blanket fear is unhelpful. Many adults don't actually know what category they're in. They assume their kidneys are fine, or they assume they're at risk because they heard kidneys are sensitive, but they haven't checked anything. If you are genuinely worried, the right move is not lifelong restriction based on a generalized warning. The right move is to know your status through routine medical care and to look at trends over time, not one isolated number. Now, none of this means you need extreme protein intake to be healthy. The point is that more than the minimum is not automatically dangerous, and for many adults, more than the minimum is exactly what makes adequacy possible. There is also a quiet irony here. The harm people fear, silent damage that accumulates over years, is exactly how low protein intake harms people too. Chronic underconsumption rarely feels dramatic. It shows up as gradual muscle loss, reduced strength, slower recovery, and lower metabolic capacity. It shows up as being more easily fatigued by normal life, taking longer to bounce back from illness, and losing more function during periods of inactivity. These changes are slow, and because they are slow, people normalize them. They assume it is just aging, or stress, or lack of motivation, when it can be a simple mismatch between what the body needs to maintain tissue and what it is being given. So the trade-off is not kidney safety versus muscle vanity. The trade-off is fear-based avoidance versus long-term resilience. Muscle is not just something you see in a mirror. It is functional reserve. It is one of the main tissues that helps clear glucose after meals. It is a major reservoir the body draws on under stress. And maintaining it becomes harder with age, not easier. So when someone avoids protein for decades because they're afraid of a risk that doesn't apply to them, they may be quietly building the exact vulnerability they were trying to avoid. That is why this topic matters. At the same time, it's important to be honest about where caution does belong. If someone has diagnosed kidney disease, especially at more advanced stages, they should not take blanket internet guidance and apply it. Their protein target should be individualized with medical supervision because disease changes the constraints. In that context, the question isn't, is protein dangerous? The question is, what protein level best supports health goals given kidney function, symptoms, and overall medical plan? But that clinical nuance does not justify turning a disease management tool into a universal warning. There is one more reason the kidney narrative is so persistent. High protein in research is often bundled with other lifestyle factors that actually do increase kidney risk, and then protein gets blamed for what the bundle did. For example, a diet described as high protein in observational studies might also be higher in ultra-processed foods, higher in sodium, lower in potassium-rich foods, and associated with higher body weight and poorer metabolic health. Those factors can correlate with hypertension and diabetes, which are major drivers of kidney disease. If protein is simply traveling alongside those factors, the association can look like a protein effect even when protein is not the causal driver. This is why it matters whether you're talking about protein as a macronutrient or about a dietary pattern that happens to include more protein. A person can raise protein by eating more lean meat, fish, eggs, dairy, or protein powder, while also improving overall diet quality. A different person can raise protein by eating more fast food, processed meats, and calorie-dense snacks. Both can be labeled high protein, but they are not the same exposure. That distinction is especially important when people point to scary headlines. A headline might imply that high protein harms kidneys, but the underlying data may not be studying a controlled increase in protein in otherwise healthy people. It may be studying a population pattern where many variables move together. When variables move together, it's easy to blame the one that sounds most suspicious. Protein often becomes that suspicious variable because it already has a cultural warning attached to it. There is also a practical misunderstanding about how risk accumulates. People sometimes think protein damage would show up the way a toxin does, where each extra gram adds harm. But if you look at how clinicians manage kidney disease, the concern is not that protein is poison. The concern is that an already impaired system has less capacity to clear waste and regulate fluid and electrolytes, so dietary targets are adjusted to fit reduced capacity. That is fundamentally different from the claim that protein intake itself causes a healthy system to become impaired. Finally, remember that the original public protein guidelines many people quote were created to prevent deficiency in populations, not to optimize outcomes for active people, older adults, or anyone trying to preserve muscle. If someone uses the minimum to avoid deficiency as their ceiling because they fear kidneys, they are using a deficiency prevention number as if it were a long-term optimization number. That is one of the quiet ways protein fear changes behavior. It turns minimums into maximums. So what should a viewer take away from this? First, the kidney warning came from a real medical context. It wasn't invented. It just isn't universally applicable. Second, an increase in kidney filtration in response to protein is not the same thing as kidney injury. Healthy organs respond to demand. Confusing adaptation with damage is a language problem, not an evidence-based conclusion. Third, lab markers like creatinine and BUN can change for reasons that have nothing to do with kidney injury, including muscle mass, training, hydration, and temporary dietary shifts. A number is not a diagnosis, and interpretation requires context and trends. And finally, for many healthy adults, the more realistic risk is not too much protein. It is too little protein sustained for years, leading to loss of muscle and loss of reserve, which makes illness and aging harder. In the next episode, we'll look at how lifting weights changes nutrition needs and why advice designed for sedentary people fails people who train. For now, the core idea is simple. Protein kidney fear came from disease management. Healthy adults inherited the fear, but not the evidence. Understanding who advice is for is often more important than repeating the advice itself. This is protein truth.